Good afternoon, everyone. In the next 20 to 25 minutes, I'll be talking about imaging the kidneys for the intensivist. The brief agenda would be like this. We'll first see the normal appearances of the kidneys, especially on ultrasound. And after that, we'll be dealing with infection, obstruction, parenchymal disease, and a few miscellaneous conditions as we go on. Now, ultrasound is the most commonly performed modality, it being portable, a point-of-care technology, non-invasive, non-ionizing radiation, and good tissue contrast. So the kidneys are typically imaged in the transabdominal route, both in the longitudinal as well as the transverse planes. So this is the longitudinal section of the normal right kidney, showing the typical bean-shaped appearance with the peripheral hypoechoic cortex. And we normally compare the cortical echogenicity or the parenchymal echogenicity with the liver on the right side and the spleen on the left side. So the normal parenchyma of the kidney is reduced or hypoechoic as compared to the adjacent liver. And within the parenchyma, you can see the cortex as well as the medullary pyramids, which appear much more hypoechoic. This varies with the age at presentation, being very prominent in the children as compared to the adults. The pyramids are much more prominent in the childhood. In the center, we have the hyperechoic structure, which is called as the central sinus, which predominantly contains fat. And this amount of fat increases as the age of the patient increases. So we have large amounts of fat in the adults as compared to the children. And this also contains the calyceal system as well as the vasculature of the kidney. This is the normal appearance. So you image the kidney in both in the longitudinal as well as in the transverse planes to look for pathologies. Now, there could be discrepancies in the appearances of the kidney, both as regards to the size as well as to the appearance of the central sinus. So in this normal variant called as a duplex collecting system, here the normal central sinus appears as a single entity, but in a duplex system, we could have two separate entities like this, one at the upper pole and at the lower pole with a central normal parenchymal band of tissue. We shouldn't be confusing this with a pathological mass or a space occupying lesion there. And the duplex kidney tends to be much larger than the opposite kidney in a normal situation as well. You could also have appearances of the normal location, being the lumbar regions on either side. So whenever you don't find a kidney in the normal location, you should be looking at it, ectopic locations in the retroperitoneum or in the pelvis, as in this particular patient. So you have the urinary bladder in the pelvis here, and you find this reniform structure posterior to the urinary bladder, with these pelvic calcium system and the vessels pointing anteriorly. Now, there could also be discrepancy in size. The normal kidneys range from 9 to 11 centimeters. That's the normal range. But in an adult patient who is a thin frame with a low BMI, it could be an 8 centimeter also, you could take it as a normal. A discrepancy of 1 to 2 centimeters between both the kidneys is again should be taken as a sign of abnormality. Normally, the left kidney is larger than the right kidney by around 1.5 to 2 centimeters. So that discrepancy in size is normal. So here you have a right kidney which appears 13.5 centimeters in the longitudinal plane. And on the left side, you have a small kidney with reduced parenchymal thickness as well as increased parenchymal ecotexture mean. And this kidney measures only 8.7 centimeters. So this is an abnormal kidney, which in this particular instance was due to a ischemic kidney due to renovascular hypertension. And the right kidney showed a bit of compensatory enlargement due to the small nature of the left kidney. Now, coming to acute kidney injury or acute renal failure setting, one of the most common causes being acute tubular necrosis. Now, you don't do ultrasound to look for diagnosing acute kidney injury or acute tubular necrosis, but most of the times you tend to look for other causes like an infection or an obstruction as a particular cause for AKI. But however, you can point to the nature of the AKI or the diagnosis of AKI by noting that both the kidneys would be bulky. They could be having increased ecotexture like this. And if you do a color Doppler and put a spectrum in the segmental or the interlobar arteries, you could have increased intrarenal resistive index. The resistance to the flow increases in these acute parenchymal diseases. So you could have a resistive index more than 0.9 here. Normally, anything less than 0.7, you take it as normal. Or if in a patient with unilateral disease, a RI more than 0.05 difference between the other kidney is again taken as abnormal. So you have an ATN here with a bulky kidney, increased echotexture and abnormal RI. You don't tend to see this all the times, but as I've said, the role of ultrasound is to look for other causes or treatable causes like infection or obstruction as a cause for acute kidney injury. Now in chronic kidney diseases, both the kidneys will be involved. What you find typically is a small kidney, reduced parenchymal echotexture, increased parenchymal, reduced parenchymal thickness and increased parenchymal echotexture with prominent central sinus containing this fat. So whenever you have this is very classical for a chronic renal parenchymal disease. Now the second thing what you usually look for is presence of obstruction. Now obstruction tends to manifest as the loss of the normal central sinus fat echogenicity. Here in the previous normal cases, we have seen that it was all compact central sinus with no evidence of any altered echotexture within. Whereas whenever there is hydronephrosis, there is presence of fluid, and as you all know, fluid appears anechoic or hypoechoic as the case may be. And here you find that there is dilatation of the pelvic calcium system, the renal pelvis is dilated, the chelicus are dilated. And whenever you have an hydronephrosis, obviously you need to trace the ureter down and look at the site as well as the cause of obstruction. Other situations where you can look other than the cortex and the central sinus is presence of medullary disease. Here you have multiple bilateral, both the kidneys, the right kidney and the left kidney, find multiple hyperechoic foci in the medullary pyramids associated with these cysts in the medulla. This is a very classical case of medullary sponge kidney. Now, the role of color Doppler in kidney disease per se is predominantly to look for renovascular hypertension and renal vein thrombosis, in addition to miscellaneous conditions like renal aneurysms or post-biopsy arteriovenous malformations or AVFs. We could diagnose that as well. Now, color Doppler is an excellent modality, especially in the right setting of a good cooperative patient as well as a not a very obese patient. We could see the aorta, you can see the renal arteries in addition to the renal veins. So we start off doing the color Doppler by assessing the aorta. You look for any aortic atherosclerosis, you look for any aortic aneurysms or aortic thrombi. Then you interrogate, look for the main renal arteries. You look at the peak systolic velocity. So any systolic velocity more than 180 centimeters per second is taken as elevated. You interrogate it at the ostium and at the paraosteal region of both the right renal artery as well as the left renal artery. Then you go on to interrogate the intrarenal arteries. You look for the resistive index as well as the acceleration time. So these are the things you look at in renovascular hypertension with regards to the renal arterial color Doppler interrogation. So this is one patient who had bilateral renal artery stenosis. You have the power Doppler here showing the area of stenosis here, but you make a diagnosis of stenosis based on the peak systolic velocity. So here you have an elevated systolic velocity on the left main renal artery. This is the aorta, this is the left main artery, more than 172 centimeters per second. You also compare and do a ratio of the renal artery peak systolic velocity and the aortic velocity. So anything, if the renal artery velocities are more than 3.5 times the aorta, then that indicates significance, and that indicates that it's a renal artery stenosis. Again, on the right renal artery also, you have elevated systolic velocities more than the renal aortic ratio, more than 5 times. The peak systolic velocity in the renal artery was 5 times more than that in the aorta. And when you interrogate the kidneys, the two things which you look at. One is the resistive index, which is the peak systolic velocity minus the end diastolic velocity divided by the peak systolic velocities. And the other is called as the acceleration time. You measure the time from the origin of the systole to the peak of the systole. So anything prolongation of this acceleration time beyond 72 milliseconds, some people take 80 milliseconds. So more than 72 to 80 milliseconds, if this acceleration time is prolonged, that again is indicative of a proximal renal artery stenosis. And one very classical waveform, what you can get in the interrenal arteries is what is called as a Tardus parvus waveform, which is highly specific for hemodynamically significant renal artery stenosis. So this catheter angiogram shows a very tight stenosis here, and the interrenal waveforms, you find that there's a very low systolic velocity and a high diastolic velocity waveform showing an increased acceleration time. There's more than 120 milliseconds, is very classical of a significant renal artery stenosis. Another patient with young patient with aorta arteritis showing increased thickness of the aorta. The right renal artery could not be visualized because of right renal artery complete occlusion, and the left renal artery showed elevated velocities, and the angiogram showed a typical ostial type of stenosis in the left renal artery. An example of a post-kidney biopsy AVM, the patient developed hematuria and loin pain, which shows that area of mosaic pattern of color you find with blue as well as red and varying types of appearance. It's called as aliasing, and when you put a Doppler, you find that there's a very discordant or a chaotic type of flow, very classical for a AVM. Now, transplant kidney malfunction or dysfunction can also be evaluated very well with ultrasound as well as color Doppler. Here, this patient came with fever as well as pain in the right renal, right iliac fossa region, post-renal transplant with the deteriorating renal function, which shows that there's a transplant kidney is here, and medial to that, close to the hilum, you find a large anechoic structure showing color flow, which was a pseudoaneurysm. And in this particular instance, it was due to a mycotic pseudoaneurysm. Post-renal transplant and angiogram confirmed this finding, and the patient had to go for a transplant nephrectomy. Now, coming to the important things, what we should be looking at in the intensive care setting in the stage of acute kidney injury or evaluation of kidneys. One of the very important things is to look for infection. In the setting of infection, you tend to do a scan, be it CT or ultrasound or MR, as the case may be. You're not going to diagnose infection basically on these imaging modalities, but you're trying to only assess or glean information about the nature and the extent of the disease. And more importantly, are going to identify significant complications of particular infection, whether there is obstruction, whether there are calculi, whether there's gas forming infection, etc. Now, in the setting of acute pyelonephritis, you could have an enlarged kidney like this with blurring of the corticomedullary differentiation, reduced ecotexture. If it's a complicated one, you could have perinephric collections or you could have renal abscesses, but you should be understanding that ultrasound is insensitive in diagnosing acute pyelonephritis. Its sensitivity is only up to 20 to 25%. In some cases, you could have a coexistent hydronephrosis like this in this particular patient with candida pyelonephritis and pyelonephrosis. So you have hydronephrosis, enlarged kidney, and these filling defects within the calculi, which within the calyces, which are sort of, when you have them, always try to rule out, think in terms of a candida pyelonephritis. Now, CT is much more sensitive and specific to diagnose acute pyelonephritis. And you'll have to remember that contrast enhanced CT is the modality of choice. And in this particular patient, we have enlarged kidney, hydronephrosis, debris within the collecting system, presence of a calculus here in the kidney, and the urinary bladder shows these debris and fluid debris levels suggestive of cystitis, pyelonephritis, and the CT shows that the left kidney is enlarged with evidence of a large staghorn calculus, left perinephric fat stranding, and a small calculus in the right side as well. So left pyelonephritis with pyelonephrosis due to an obstructing calculus. Now, this is the classical appearance of acute pyelonephritis. So where you find that the kidney is enlarged, it's globular as compared to the normal reniform appearance on the right side. Areas of these three key hypodensities extending from the center towards the cortex, small hypodense foci. And in an excretory phase where you see contrast within the calyces, you find that again, these areas of low attenuation, very classic for acute pyelonephritis. Now, one thing what you should be suspecting, especially in uncontrolled diabetes or patients with diabetic ketoacidosis, is presence of air within the collecting system or within the parenchyma in a setting of emphysematous pyelonephritis. So on an ultrasound, you find enlarged kidney with hypoechoic appearance, presence of these hyperechoic small foci. You shouldn't be mistaking them for calculi because these show dirty shadowing, whereas calculi show neat or very well-defined posterior acoustic shadowing. And the bladder shows here a presence of air within the urinary bladder. And a corresponding CT shows presence of air within the collecting system. So when you have air within the collecting system, that indicates a lesser degree of involvement, vis-a-vis air within the renal parenchyma or in the perinephric space, which indicates a much more serious type of gas-forming infection. So this is the more serious form where you find that there's a large air fluid level in the right renal area, and the contrast enhanced CT shows enlarged kidney, almost destroyed parenchyma, multiple foci of air within the parenchyma and in the subcapsular collection. So this patient couldn't be salvaged with medical and conservative management, and he had to undergo a right nephrectomy to control the infection. Now, renal abscess tends to be more focal. So like this, where you have a hypoechoic lesion with evidence of internal echoes. Color Doppler will not show any flow within the lesion, but there could be increased flow adjacent to the lesion. And it's important to identify renal abscess because these abscesses could be drained either image guided or surgically for complete cure. So on a CT, it shows as a hypodense lesion, rim enhancement, no enhancement in the center, perinephric fat stranding. So this is very classical for a renal abscess. Now coming to the second important indication or thing which you should be identifying is presence of obstruction. Now, ultrasound is very elegant and very simple to do for detection of obstruction. So you could grade the degree of obstruction based on this grading system, which is usually used for fetal ultrasound, but can be used for adults as well. In the grade 1, where you find that the central sinus separates and you find a thin linear streak of fluid within the collecting system. In the grade 2, we have areas of more increased dilatation of the central sinus with some dilatation of the calyces, and it's more marked in the grade 3, where you find more pelvic dilatation. But however, the renal contour is maintained, the renal thickness is maintained, whereas in grade 4, you have areas of marked dilatation of the calyces with ballooning and thinning of the cortex. So this is how hydronephrosis looks on ultrasound. Caveats include you have a parapelvic renal cyst. Sometimes you could mistake it for hydronephrosis, and non-obstructive dilatations also could be there. We'll see a few of them later. So this is an example of hydronephrosis with hydroureter. You find that there's a hyperechoic calculus at the right vesicular junction due to a right VUJ calculus. And one trick what you could utilize is sometimes you have multiple hyperechoic things. You're not too sure whether it's normal fat or calculus. However, here it shows this clean type of posterior acoustic shadowing. This is a very classical for calculus. But sometimes you could also put a color Doppler over that calculus, be it in the kidney or be it at the VUJ, and you find this artifact. This is called as a twinkle artifact at color Doppler. And when you find this is very classical for presence of calcium or calculus, and it's not a fat or other structure. So when you have this twinkle artifact just behind the hyperechoic structure, it's very classical for a calculus. Now, one other situation where ultrasound and color Doppler especially are very useful is evaluation of renal colic in pregnancy. Now, ultrasound is the preferred modality for obvious reasons of non-ionizing radiation. Here, you could use two tricks to look for presence of obstruction. As you all know that normal physiological induced hydronephrosis occurs in the maternal kidneys, especially on the right side. So when a mother presents with pain, especially on the right side, you're not too sure whether it's an obstructed system or whether it's a hormonal induced pelvic ectasis. Here you could use intrarenal resistive index. You compare the RI from the index kidney to the opposite kidney. Here you find that the RI is 0.84. It's elevated as compared to the left kidney, which does not show any dilatation, and the RI is 0.70. So elevated RI, symptomatic kidney, you need to take that as a sign of obstruction. The other thing what you could see in the same patient is you put a color Doppler over the uretrovesical junction at the VUJ. So normally when due to the peristalsis in a normal non-obstructed system, when the urine flows through the ureters, this is the terminal ureter, you find that you have the color picking up due to the ureteric jets. So whenever you have ureteric jets, that means that that particular system is not obstructed and it's a patent system and it's not, it is normal. So whenever you have a obstructed, dilated system in a mother, in a maternal kidney, and you find that you find this ureteric jet is there, you can be rest assured that that system is normal and it's not an obstructed system, and the dilatation is not due to an obstruction. So two things in a maternal kidney with the dilatation: look for RI, look for ureteric jets. The same thing can be looked at in adults, other non-maternal conditions as well. So whenever you have a pain on one side and you find that the ureteric jet is present, you can safely exclude obstruction on that particular side. Again, MR can be performed much more safely than CT in a pregnant patient who comes with causes of acute abdomen. So here this staff nurse presented with pain abdomen. This was due to an acute appendicitis on this T2-weighted axial image. At the same time, the patient also had a calculus in the left PUJ, which was causing severe hydronephrosis. So MR is excellent. If ultrasound is equivocal, you could do MR to look for changes in the kidney as well as changes elsewhere outside the urinary tract. Now, this is an example of MR urogram. This patient presented with acute on chronic renal failure, a 16 years old boy. The KB shows these multiple large C type of large calculi bilateral distal ureters, and the MR urogram non-contrast shows this severely dilated pelvic axial system, tortuous dilated ureters. MR can very well show this, especially in the setting of renal failure. Another example of post-renal transplant condition with urinary obstruction, hydronephrosis, hydroureter, and you could find that there's a collection at the level of the VUJ causing obstruction. So this is the urinary bladder, this is the VUJ, and there's a collection there which is due to a post-op transplant urinoma, which is causing compression and hydronephrosis. This patient was treated surgically. Coming to a few vascular conditions, what you can detect on color Doppler as well as other conditions. One is arterial injury to the kidney. In this particular patient with motor vehicle accident shows, in the contrast enhanced CT, shows complete lack of enhancement suggestive of renal arterial occlusion here. There's also associated hemoperitoneum. Now, sometimes the injury could be segmental in nature, where you find a segmental infarct. Again, patient fell from height, which was due to a segmental arterial infarct, also had a splenic injury here. And another patient with the severe retrosternal pain, the clinical diagnosis was aortoarteritis, which shows a long segment thrombus in the distal thoracic aorta extending into the upper abdominal aorta. And here you find that there's a large wedge-shaped hypoperfusion in the right kidney, which was due to the thrombus extending into the right renal artery as well as into the celiac axis, the superior mesenteric artery. So this is the renal arterial thrombus extending from the aortic thrombus with presence of multiple these segmental infarcts. There's also occlusion of the celiac axis as well as the SMA. So if it's bilateral, then it can lead to a situation of renal failure as well. A much more serious and an irreversible condition, this patient we have seen 2 weeks back, post LSCS with severe bleeding, with hemoperitoneum, with acute acute kidney injury. This shows the typical appearance of acute cortical necrosis, where you find that enhancement of the medulla and typical circumferential diffuse hypoenhancement of the cortex, a dreaded condition of acute cortical necrosis. Same seen in the axial contrast enhanced CT. You also find large areas of hypoperfusion in the liver, probably having liver ischemic infarcts as well. A miscellaneous condition of this patient who presented on hemodialysis with severe right-sided pain. Here you find that the kidney is hyperechoic, the normal texture is gone. Here you find hyperechoic appearance in the lower pole of the kidney on the right side. This is the liver. MR is very elegant to look for presence of hemorrhage and presence of infection as well. So here you find that the right kidney is enlarged, the left kidney is shrunken. You find this hyper intense hemorrhage within the right kidney, again shown much better on this fat suppressed image. And the T2 weighted image shows the small left kidney and an enlarged right kidney showing intense appearance due to the presence of acute hemorrhage. And this patient had expanding hematoma and had to undergo surgery. And this is a specimen showing the large area of acute hemorrhage in the right kidney. Now, another one setting where again MR is excellent after an equivocal ultrasound is evaluation of a patient of ADPKD who comes with pain in the flank. The pain could be due to obstruction, pain could be due to hemorrhage in a cyst, or due to an infection in a cyst. Now, a T2 weighted MR urogram type of image shows that both kidneys are enlarged, multiple cysts in both kidneys. There is mild hydronephrosis on the right side. There is a dilated pelvis as well as the calyces. And there are areas of low intensity suggesting presence of hemorrhage within this cyst, and also areas of calcification. So whenever you have a patient with ADPKD presenting with flank pain, you want to rule out obstruction, you want to rule out infection, you want to rule out acute cyst hemorrhage. If ultrasound is not showing up, MR would be the next modality of choice. So in conclusions, ultrasound is the modality of choice in kidney imaging, given its various advantages. However, the main role of imaging in acute kidney injury or renal conditions would be to exclude obstruction, to look for complications of infection, to look for calculi, and to look for vascular conditions, especially using color Doppler or contrast enhanced CT or MR. Now, CT is predominantly used for detection of calculi and to map the extent of infection, and to, more importantly, to detect complications. And MR would play a role where ultrasound and CT cannot be done, or you need more information, especially in the setting of pediatrics and pregnant patients, where ionizing radiation is usually not performed. Thank you very much for your patient hearing. Any questions are welcome. Thank you very much.